Good morning, friends. This talk is about fractures in children, something about which you are also going to hear another one of my older talks along the similar lines given a little while ago, I think a few years back. What is very important for us to understand is that do fractures in children ever need metals or implants? And which fracture below 14 years of age needs surgery, if any? In most of the orthopedic group, whenever I see a child with any fracture child below 7 years with any fracture, the most common and the first knee-jerk reaction from the participants is pin it or put K-wire. Question is, are we over treating the fractures? Number one. Number two, are we forgetting the remarkable powers of remodeling of the patient? Number three, do children with fractures treated surgically fare better or worse than those treated non-operatively? This talk will try to answer these questions. However, let me start with a serial radiograph picture of a 5-year-old girl followed up for a year. So you can start see date of injury after 3 months, after 12 months. The overriding was neglected. No attempt at active management was made. No efforts were made to correct anything. And in 12 months, you can see complete remodeling. With commercial interest, implant manufacturers, insurance companies, and vested interest taking over the arduous job of manufacturing evidence, propagating open reduction and internal fixation, the current modalities for fracture treatment are increasingly shifting towards radiological perfection rather than the patient's benefits. Fractures in children, which unite and remodel beautifully, most often without treatment, are being increasingly operated these days for simple cosmetic management of the X-ray, despite the very high risk, low benefit ratio. I personally stand by the following 3 rules, which I recommend to all viewers as well. Commercial evidence, Campbell, or any textbook notwithstanding. If the books are giving anything opposite to this or contrary to this, please believe me that they are influenced by commercial ideas and are sponsored by implant companies or written by, the chapter is written by persons without any experience of experiencing the miracles of what remodeling can attain. No child below 3 should receive surgical management for any fracture. The indications for surgical intervention in children below 10 are extremely limited. Pediatric fractures seldom need open reduction and very rarely need internal fixation. A fracture does not displace more than it has during the initial injury. Rather than relying on K-wires, one must rely on appropriately molded cast with the adjacent joint or joints in correct position. If the fracture is very close to one joint, it is no longer considered essential to immobilize one joint above and one joint below. The time of fracture healing in children is so much lesser than adults. Thus, younger the age, faster the union. Likewise, younger the age, greater is the remodeling potential. So, no limb fracture unites before 3 weeks. Lower limb fracture takes twice as time as upper limbs. Fracture in children take twice as long as infants. Fracture in adults take twice as long as children, and compound fractures take twice as long as closed simple fractures. Needless surgery with ghastly metal is not only unnecessary but can also be called as criminal surgery, as seen in examples below. You can see a 3-year-old femur treated with a thick K-wire, a 3-year-old boy treated with an adult narrow DCP and then with a cast. Such crimes deserve punishment. This is a punishment both for the child and the parent. You can see again how a child's femur was criminally plated and then resulted in a bad infected non-union and pseudoarthrosis, which needed extensive management to get him back to an equal limb. This is a fracture of the ulna treated by a plate. This was treated at the age of 7 years, and this is a child at the age of 10 years. This is called a man-made disaster and a punishment for the child. Once again, a shaft of femur, which would have united beautifully by a weak traction, followed by a walking long leg cast, was treated by fashionable intramedullary implants which distracted the fracture, and it finally went into non-union. The implant had to be removed and a walking cast had to be applied to compress the fracture to unite it. On the contrary, you can see a fracture in a small child of about 1.5 years, which was left alone. You can see how the callus forms in a week's time, and the X-ray on the right will show you the progress in 3 months, and in 6 months, the major shortening was equalized and the limbs became equal. Look at this. Can anything be more ridiculous than this? Putting a DHS in a 5-year-old child and then reinforcing it with a 1.5 spica. Such surgery I call as criminal surgery due to an ignorant surgeon. We must educate the surgeon and, more importantly, educate the parents also, who want a perfect treatment for the X-ray and hop from surgeon to surgeon in search of someone who will put some fashionable metal and show them a perfect radiology. See the large incision that has been put for this child, which extends to almost half of his thigh, and this boy will have to bear his scar and non-union and the complications and the possible complications of anesthesia for his entire life. You can see another basal trochanteric fracture in a small young child who was 2 years old, and within 6 months you can see the results of infection, plate removal, and iatrogenic non-union and a severe varus. Another case you can see disastrously fixed with improper implants, already infected, see the lights around the screws, and furthermore, you see the heavy, bulky, cumbersome cast. This goes against all orthopedic principles of either casting or internal fixation, and once again is a great punishment for the child by an ignorant practitioner. On the contrary, see this one, no attempt has been made to reduce the distal radial fracture, just has been mobilized in a cast which, in my opinion, is rather thick, and in 6 months, it has united, remodeled, and straightened. Another one, you can see the fracture at 4 weeks and at 6 weeks, and see how beautifully the fracture is united and remodeled. One more identical fracture to this. This fracture was just treated non-operatively, and in 4 and 6 weeks you can see the result. And this fracture, the intelligent surgeon wanted to treat the X-ray, and then he put wires in a mal-reduced position, and the fracture remained ununited even at 4th month. See this, such a simple fracture in a small child, punished with wires in the tibia, a plate in the fibula, and a huge plaster. I'll move away to see this. All this needed was straightening and a very light walking cast, and would have united and remodeled in 1.5 months. And here, the surgeon has elected to punish the child for the sake of radiological cosmesis, and this fracture too went into infection. This is how fracture is treated biologically in a child. You can see the overriding. Nothing was done, just a very small short arm necklace cast was given, and the child was encouraged to move the hand from day one, and on the right side is the position in 6 weeks. In 6 months, this arm X-ray would be radiologically indistinguishable from that of the opposite side. In very young children, no immobilization is needed except for a sham plaster for the parent satisfaction, which can be in the form of an elastoplast bandage around the limb. In older children, lightweight cast, featherweight cast, concentrating on the joint position, proper precise molding, and a 3-point fixation most often does the job satisfactorily. One must remember that traction has a valuable role in pediatric fractures, and these are well tolerated because the duration of traction is just 2 to 3 to 4 weeks. It is very easy to send a nurse to the patient's home and put the traction in the patient's house. The time of nursing that the parents spend with a child treated surgically is itself 2 to 3 weeks. A similar time can be spent at home by the mother or father by taking leave from the office, and the trauma and stress for the child is much less, complications are nil, and results are far, far superior. It is very important to counsel the patients and their parents about the profound remodeling capacity in children, and then show them the charts, files, screen images, etc. before commencing the treatment, and explain to them that the initial X-rays may not look good, but will certainly get better over time. I take a proper consent from all my patients, explaining all available forms of treatment given in the book, and show the results and charts of various children who have healed and remodeled. And then I ask the parent to make an informed decision. I repeatedly tell them that my treatment is not aimed at producing a perfect X-ray, but at restoring as much normal function as possible. And I tell them that I can assure that in a year or 18 months, the child will have normal results. I also tell the parents that if they take the X-ray and go shopping to other surgeons, they will be barred or banned from returning to my clinic. And if they get surgically operated, I would never again see the child in my life. No fracture in children except 3, in children below 3, except congenital pseudoarthrosis of tibia ever needs surgery. Please keep this in mind. In children between 3 to 8, accurate reduction is needed in supracondylar fractures of elbow and pinning in displaced lateral condyle fractures of elbow. So, a displaced lateral condyle of elbow is the only indication for surgery in a child below 8 years. I have never pinned a supracondylar fracture in my life. By gravity reduction and hyperflexion, a simple cast can retain hairline reduction for 3 weeks, which it takes for the fracture to glue. Between 8 to 14 years, lateral condyle needs reduction and fixation. One may elect to pin a well-reduced supracondylar elbow, but again, no other fracture, including femur, needs any form of metal. The argument about busy parents can't take time off to look after a child in spica and early mobilization are all commercially driven. A child with tense nail needs as much time and support from the mother as a child in spica. Please think seriously whether you would have administered the same management to your own son or daughter if she or he had sustained a similar fracture and then only proceed to surgery. Even today, numerous orthopedic surgeons who operated hundreds of children, when their own child suffers a fracture, send me X-rays on my personal WhatsApp asking me what is the best way to treat his child non-operatively. You can see a similar fracture, one treated non-operatively in the X-ray above and the other treated operatively in the X-ray below. Both results at the end of 10 months. Above image has become anatomically accurate despite the overriding at the time of fracture. On the contrary, the one below, you can see the disaster of infection and virus and lifelong fiasco for the poor patient. See the result of a non-operative management of a 13-year-old boy who was advised tense nailing by not one, but by 4 orthopedic surgeons. He had the index surgeon had both consulted me and posted on our group. He was advised Thomas Flint fixed traction for about 15 days, followed by a long leg walking cast. And there you can see his movements and his X-ray at the end of 4 months. The anterior bowing will disappear to normal and become straight in 12 months. Many years ago, I written, drawn, and edited a comic book style manga narrative to be made as a handbook for the parents. In the following slides, I will quickly run through them without a narrative because the same is being covered in a longer talk posted earlier, which for the sake of completion of this biological course lesson shall also be included in this same lesson. So I shall run the slides rather quickly. So this is fractures in children, the matter which I have already told you earlier. In 1976 edition of Watson Jones, only 3 indications for surgery in pediatric fracture: congenital pseudoarthrosis of tibia, osteogenesis imperfecta, and lateral condyle humerus. The recent edition of Rockwood and Green has 23 indications for surgery. What has brought about this change? Pure commerce and commercialization and insurance, because a plaster makes no money for anybody. On the contrary, surgery makes money for the whole system, the hospital, the nurses, the doctors, the pharmacy, and the insurance company. So that is the Watson Jones book, and that's a classical example of a child who had a 90-degree angulation at birth fracture, and you can see on the left how this has united, remodeled, and equalized over a period of time. So we must treat the child, not the X-rays. All these X-rays and series will be shown in a talk subsequently. This one is my own patient, and a video of this will be also shown in the talk on extension casting. This is the final post-operative X-ray of this young girl, and you can see how the fractures healed beautifully and remodel, unless the surgeon enters the room with flexible nails or plates or other things. So you can see that fractures in children do not need surgery. This is another recent finding that even a single episode of general anesthesia in a child has been linked with long-term consequences like ADHD, reduced attention span, and a few psychiatric issues due to jolting of the cerebral cortex due to anesthesia. So I repeat, be wary of indiscriminate anesthetic use in children. Avoiding few minutes of pain is associated with lot of risk. Give hematoma block, give a little sedation. Even if the child screams a little, give oral anesthesia and reduce. This child was treated in the clinic and the plaster gator for 9 days, and see the results. See how fracture untreated remodel. You can see how a neck of femur in a child, which was advised surgery by some great surgeon, eventually remodeled to normal. You can see the remodeling of a femoral shaft fracture, an unreduced neck of humerus automatically remodeling, a tibia by side to side apposition becoming straight, a femur by side to side apposition becoming straight, a distal radius again untreated becoming straight. That's the humerus of head in another child which is getting back to normal. Shaft of femur with complete remodeling, a shaft of femur with remodeling and also regaining its length, becoming equal to the opposite side within less than 18 months. On the contrary, see, somebody tried to put a just fixator in a child and K-wires caused the mess, and see, 5 years later, the patient has ended up with an acutely short limb, with a varus deformity, with puckered huge scars for K-wires. Again, a criminal punishment by the surgeon to the poor hapless patient who has no say in the matter. And this is what happens if you do not touch a similar fracture. Once again, another example, yet another example, and this is how it tends to distract and cause complications. So the manga comic ended up saying that don't treat X-rays, treat patients. Anxious parents seek perfect X-rays. We must treat perfect function. Pins, wires, tens are bad for the child who is prolonged GA. Best results of conservation in a child are always better and superior than best results of surgery. See the forearm treated by an extension cast on day 1 and the final results in the second X-ray at the end of 6 weeks. You can scan the QR code on right to get a download link of this manga comic, which is the PDF version, which you can share with the parents so that they can understand that their child does not need surgery. And furthermore, you can also share a YouTube link of this particular video to the parent so that they will not do window shopping or go to someone else for surgery. Thank you very much for patiently listening to this talk. And this talk is based on a chapter on a newly published book by IAOS, Orthopedic Beyond Books, and shall also be a part of IAOS course, online 4-month course on biological and non-operative management of practice. You will find my WhatsApp number at the end of the whole lecture, and you can personally WhatsApp me if you are an orthopedic surgeon, a primary care provider, or somebody who treats broken bones, and I shall be happy to give you complete details. Thanks for your patience and hope you enjoyed listening to this lecture as much as I enjoyed delivering it. Thank you. To learn these new techniques, feel free to message on the WhatsApp number given above. Please only messages and with your name, designation, qualification, telling me what you want. This is only for qualified medical professionals. If you are a patient, please send me a text message only. If you do not know English, send a voice message in Hindi or some other language, but no calls. Welcome to the IAOS way of new learning and teaching. Thank you for patiently listening to this lecture. Thank you very much.